Hey guys, for those of you who don't know me, my name is Jean. I'm one of the ENPGY2s. So I'm going to be giving an ultrasound lecture on cardiac tamponade and pericardiocentesis. Before I start, I just want to thank the ultrasound lecture team, Dr. Sanson, Dr. Belyavskaya, Dr. Lingam, and Dr. Maria who helped with this lecture. I'm going to start with a case. So we have a patient that comes in with the chief complaint of needing to see his cardiologist. He's a 63-year-old male with a past non-cluster, CAG status post stent placement, hypertension, diabetes, B2H abuse, and hepatitis C, who presents with complaints of sudden onset chest pain 30 minutes ago. He describes the chest pain as sharp, mid-sternal, non-exertional, and radiating to the back. And he says that it's not associated with any kind of shortness of breath. On exam, his vital signs are significant for a blood pressure of 104/78, a heart rate of 81, an oxygen saturation of 100, and a respiratory rate of 20. Otherwise, his cardiac and respiratory exams are pretty benign. His normal heart and lung sounds. Can someone interpret this EKG for me? Maybe one of the juniors?
Normal sinus with electrical currents.
Yes, so we're talking about cardiac tamponade. So we have a low voltage, normal sinus EKG with evidence of electrical alternates. So we have our usual suspects for chest pain on the differential. We have ACI, aortic dissection, pneumonia, pericarditis, and pulmonary embolism. I talked to his cardiologist who told me he'd gotten a CAP in December of 2018, at which time he only had a 40% occlusion in his LAD. So it's very unlikely that this was an occlusive pathology. The patient did not have any recent infectious symptoms, and he had no PE risk factors. So despite the fact that he wasn't hypertensive, since the character of the chest pain was radiating to the back, we decided to get a CTA to rule out an aortic dissection. This is not the exact CT, but pretty much what it looked like. And it's clear what we should have done is grab ultrasound, so we see is pericardial effusion.
Right.
So cardiac tamponade happens when fluid in the pericardium builds up enough pressure to exceed the pressures in the cardiac chambers, which impairs cardiac filling. Tamponade is often described as a clinical diagnosis, with the patient presenting with X triads, specifically hypotension, muffled heart sounds, and jugular venous distension. However, ultrasound findings often precede the clinical signs of tamponade, so it's important to identify what those ultrasound findings are. Ultrasound also allows for diagnosing the presence of an effusion, reporting the size of the effusion, which has implications about prognosis, and assessing for hemodynamic significance. Chamber collapse, usually the right atrium and the right ventricle, which can be documented on ultrasound, indicates that the intrapericardial pressure transiently exceeds intracardiac pressure. So the objective of this lecture is going to be to talk about how to identify tamponade physiology on ultrasound, including the probe of choice, how to obtain the appropriate images and measurements, and how to interpret those images, and then also how to perform an ultrasound-guided pericardiocentesis, which is our management of unstable cardiac tamponade, which is the definition. Okay, so our probe of choice is going to be our cardiac or phase array probe due to its smaller footprint and its ability to get in between ribs. To obtain images, your main finding is going to be RV diastolic collapse. However, you can also look for right atrial systolic collapse, which is less sensitive and specific. I'll talk about that later. The last thing you can look for is the plethora of the IVC, as well as mitral or tricuspid inflow variation with respiration, which I'll talk about more later. Our first view that we're going to look at is the peristernal long view, and you can either try to get an image where you see the literal collapse of the RV as the mitral valve opens, or you can use M mode if this isn't easy for you to get. We'll start with the video here. So you can get a good shot of the peristernal long. You can try to just get a freeze of it, like here, and then you can slow it down a little bit to catch where the mitral valve opens. Here, you see the mitral valve is open, and you see the right ventricle here is collapsing down. And that would be a sign of your right ventricular diastolic collapse. But this isn't always as easy as it looks to catch. So the other way to get this would be to use M mode and look for tamponade physiology. By placing M mode over the mitral valve and the right ventricular outflow tract on your peristernal long view, you can see the movement of the right ventricular outflow tract in accordance with the E and A wave. The E wave, which is the beginning of ventricular diastole, and when the mitral valve opens, is exactly where you would see this right ventricular diastolic collapse, which we see here. Here, just going again through exactly how to do this, but diastolic collapse of the right ventricle carries a high sensitivity. It ranges from 75 to 90%, but with a relatively lower sensitivity. For example, if the right ventricular filling pressures are elevated at baseline, follows the diastolic collapse, will be less likely to occur. This may be the case with acute or chronic pulmonale, pulmonary hypertension, severe left ventricular failure, and other etiologies of right ventricular hypertrophy. You can also look for right ventricular diastolic collapse on other views, not just the perispiral long view, but those may be more difficult to see. You can't use the MMO that I should just talk about. Another way to assess for tamponade is via inflow variation, which is the sonal equivalent for pulsus paradoxus. Just a quick review for both me and you. Pulsus paradoxus is a normally large decrease in stroke volume, systolic blood pressure, and pulse rate and amplitude during inspiration. The normal fall in pressure is less than 10 millimeters of mercury, but due to increased intraventricular dependence that you see in tamponade, this number increases. So this measurement is obtained in the 8-4 view, and it's a measure of the mitral valve and tricuspid valve inflow velocities. You do this by using pulse wave Doppler, the same thing that would be used to measure like diastolic function, with the gates placed at the tips of the valve leaflets. The flow velocity should be measured at the first heartbeat after the change in respiratory phase, but more simply put, you're measuring the tallest E wave and comparing it to the shortest E wave. And if you see a greater than 25 difference between the two on the mitral valve and a greater than 40% difference on the tricuspid valve, that would be a sign of pulsus paradoxus. I tried to find some research on the sensitivity or specificity of this finding, and I didn't have a lot, but this is just another adjunct finding that you can use when looking for cardiac tamponade. The last thing you want to look at is IVC, as it's a marker of central venous pressure. Large caloric lead pipe IVC further confirms obstructive shock due to tamponade. This is a very sensitive sign for tamponade with a sensitivity of 95 to 97%, but has a much lower specificity, obviously, because there are several other cardiac conditions, including CHF and tricuspid regurg, that will give you a large IVC. But on the other hand, it is important to note that a collapsed IVC does not rule out tamponade. You could have somebody who is hypovolemic in the setting of trauma, cardiac tamponade, you would have a collapsed IVC as well. And then patients with loculated pericardial effusions may also have a collapsed IVC. So just because someone has a collapsed IVC does not mean they do not have tamponade. Okay, so since we've gone through all of the ultrasound findings for cardiac tamponade, we just wanted to go through a few of the pitfalls on ultrasound of cardiac when you're looking for cardiac tamponade and pericardial effusions. Like I said, right ventricular diastolic collapse is a more specific but less sensitive finding for cardiac tamponade compared with right atrial collapse. Right atrial systolic collapse may simply denote atrial systole. However, so I didn't talk about this in detail because it seems very convoluted when I was reading about it. If the right atrial systolic collapse lasts greater than 1/3 of the cardiac cycle, the sensitivity and specificity of this ultrasound finding for cardiac tamponade greatly increases. It gets to almost 100%. I just don't know how you would measure it. You always want to document IVC size and possibility as it's designed with increased right-sided filling pressures. Next, diagnosis of cardiac tamponade is particularly difficult in pulmonary hypertension and right ventricular failure, specifically because these conditions are more often associated with pericardial effusions at baseline. And finally, although tamponade is a clinical diagnosis, ultrasound findings may precede the clinical presentation, and subacute tamponade may not present with the clinical findings you normally appreciate. Okay, so now that we've talked about how to look for tamponade, we're going to talk about how we're going to manage it, especially using ultrasound. In order to start pericardiocentesis, you're going to grab your supplies. These include a spinal needle, 18 gauge would be good, a large syringe of 20 to 30 cc's, and a sterile gown and drape, as well as an ultrasound and throat cover if you're going to do this ultrasound guided. I'm going to be talking about two approaches to pericardiocentesis, specifically the subxi and the peristernal approach. The subxiphoid approach, many people know, is often done landmark guided, but you can also use a probe to assist you. In this case, the probe is placed in the subxi area, angled up into the chest using the lever as a window. The needle should be inserted parallel to the probe and directed at a 45-degree angle towards the left scapular tip. The needle should appear on the screen as a hyperechoic structure and should be used to guide the advancement towards the pericardium. And as you advance the needle, you want to be aspirating every 1 to 2 millimeters until you get fluid drawn back. The next approach is the peristernal approach and is more often done ultrasound guided. Here, the probe is placed on the chest wall in a left peristernal position at approximately the 4th intercostal space to obtain a peristernal long axis view of the heart. The needle should be inserted at a 45-degree angle in plane to the probe on the anterior chest wall and directed toward the effusion. The ideal insertion site on the chest wall should be close to the area where the effusion is the largest, obviously. And then again, here you're going to be aspirating as you insert the needle every 1 to 2 millimeters until you get fluid back. The peristernal approach is often preferred over the subxiphoid approach due to the closer proximity to the pericardial effusion and a better ability to avoid the liver and the lung. But there's not really a lot of data on which one is more superior and has less complications. We're actually going to look at a video after I'm done here on exactly how this is done. That was done over at Penn State. So finally, just to summarize, when assessing for cardiac tamponade, you should look first for diastolic collapse. This is a pretty specific finding. And although radial collapse may be present, it's not as specific for a tamponade unless it has an increased duration within the cardiac cycle. You can also look for mitral tricuspid inflow variation as a marker of tamponade, just an adjunct finding if you have the time or you're not sure. And you should always be obtaining an image of the IVC to support your findings. Finally, although tamponade is considered a clinical diagnosis, you may see these ultrasound findings before you get to the point where your patient is unstable. In addition, if you have subacute tamponade requiring pericardial window, those patients will not necessarily ever present with the classic Beck's triad that you're looking for. Okay, that's it. And we're going to look at a video now. How do I put this up?
Is your video here? Great job.
While we're waiting, it just like good point. It's really important to diagnose that subclinical tamponade. Like the patient might not be in frank shock, they might not be hypotension altered, but they have like ultrasonographic findings of tamponade, which means that they might not be in clinical tamponade now, but they might in 20 minutes from now, or an hour from now, or a day from now. Those patients don't need emergent pericardiocentesis, but they usually need to emergent management, so like a window.
Yeah.
So that's why it's so important to identify those patients, because they're going to go for a window probably that day or within 24 hours.
And you can start like fluid loading them a lot earlier. Like for example, the patient I had at the beginning of this presentation ended up becoming hypotensive by the time I put an ultrasound on their chest, and we had seen the CT. But if I had seen that ultrasound finding earlier, I might have been able to get into the pericardial window earlier, get fluid loaded earlier before the patient became hypotensive. So there's no reason to be waiting until you see Beck's triad to diagnose this. Okay.
Sorry, I actually had a question about that too. Was there data about the sub?
Dr. Willis, we have a question in here too. Give us 1 second.
There was a discussion on MPRED a couple weeks ago between Weingart and Jacob Avila, in which they're trying to separate this idea, pushing back at what you've heard since your grandparents were physicians, that tamponade is a clinical diagnosis. Their pushback to that is, well, that's like saying pneumothorax. You have to wait until it becomes a tension pneumothorax before you consider a pneumothorax to be a real diagnosis, which we all know would be absolutely ludicrous. The advantage of ultrasound is really trying to figure out, can we identify this early so we can do the appropriate intervention? You're doing ultrasound early, great. We identify tamponade there so that you can get them to surgery, so they can get into get that much safer window in the OR versus like all of that small select group that actually needs emergent pericarditis in the ER, which is a much smaller subset. And you can, if you look at our role in the ER, you can say each one is incredibly valuable. Like finding those people who are saying, well, they aren't just able to go to the floor and identifying that tamponade is real. They're just not in super tamponade that I have to intervene at the second right now.
I mean, the truth is that most tamponade you identify are not in need of pericardiocentesis. You're going to get a window because it's much better. I've seen way too many pericardiocentesis fail. Windows are definitive management. That's like the ideal. But obviously, sometimes you're not going to have a choice, so you should know how to do a pericardiocentesis. Most of the patients you're probably going to identify in your career with tamponade are going to be stable enough to get the window.
Dr. Willis, you had a question?
Yeah, Dr. Willis.
Semantics.
I was just going to ask, I agree with what Dr. Schechter and Dr. Kilpatrick are talking about, and I've had similar experiences. Has there been any literature or papers kind of looking at seeing those ultrasound findings and then following where the clinical findings come up? Is there like a specific time course or like a specificity or sensitivity of, how many of these actually go into clinical tamponade? Just curious.
Honestly, I didn't find any papers or read anything on that, honestly. Yeah, just more on like how specific those findings are for tamponade, but not necessarily the timing of it.
Yeah, what a lot of us tried to find and couldn't was the paper that said false positive. Like, how many times are we identifying it and saying this is tamponade, this is tamponade, this is tamponade in the ER, and it sits in the CT ICU for days and never develops any further. And I couldn't find that paper anywhere. Go looked, everyone else looked. So we fall back to those papers that you found about being specific for identifying tamponade, but not what happens to the ones we think are real that aren't treated as such. Like how quickly do they evolve into something else? I think it'd be such an individual case-by-case basis. Is this coming out because it's the 20-year-old who had a supposed viral pericarditis? They evolved very quickly. Is this someone who is post-radiation treatment, and that's why there's inflammation, the pericardial sac, so it's going to develop slowly? It might be weeks in the ICU, or you go home and then come back a few months later before that really becomes actual tamponade. But yeah, I couldn't find a paper on that.
Yeah, that would be interesting. Yeah, I'll look at that too.
The difference in approach, I think, is great because if nothing else, it speaks to what do you have access to. I mean, we're more comfortable historically is doing a sub-eye approach, and that's just again how everyone was trained. But if nothing else, when you look at those images, you can see your limitation of what you have access to needle-wise would really affect your likelihood of success. When you're doing that sub-eye approach, you need at least 5 centimeters. All of a sudden, that really narrows down what equipment you can use. You have a spinal needle in your pocket? Probably not. Is it your backpack? Maybe. Certainly, the couple I've done in the arrest situation were ones where you actually went to the introducer for like a central line, and because that one's about, I think it's like 5 or 6 centimeters, so we get that had enough depth to get there. You shift over to that peristernal approach, you only need 2 or 3 centimeters, unless you're Charkerzad and work out heavily, get through all that pectoralis muscle. You probably just a few centimeters to get to that same space. So all of a sudden that 18 gauge that you have in every single cart is feasible to get to that fluid, and you don't need a specialty needle to achieve that. Just thinking back in the most recent case that sent back to us as why the ER pulled out 30 cc's and they went to the OR and they pulled out 1.5 liters. Well, probably that needle just barely got to the space, they pulled the fluid and lost it, versus the other approach, they had to really use your time getting there.
Yeah, I wonder if I wish there was more papers on what the complication rates would be between the two.
Yeah.
I had a case at UHB a few years ago. An employee at UHB had been standing up for a while and had a near syncopal episode. And she came in and she had orthostatic, but laying down she was okay. And at the time, our ultrasound fellow was around and she put on the probe. And she saw the tamponade, she saw the right ventricular collapse, which is when this woman was lying down, and I'd given her some fluid. She seemed okay. So, but definitely you could see it on ultrasound, right? Even when she seemed okay. So we called cardiovascular surgery here, thoracic surgery here, and they didn't want to take her to the OR. And I got the cardiologist. He said, look, she's going to deteriorate if you don't, even if she now seems better after a liter of fluid. And he pushed and pushed, he was right. And they finally took her and did the window, and then she did really, really well. So I think you're right, that if you see that with some kind of symptoms, you can't wait.
Yeah, we start getting literature about like the cases that are missed. Like it really is, those are something else masquerades that's much more common. Like a rapid AFib history is coming in, you find diastolic and drift in it, and you know, people are not like thinking, let's do the echo, let's look for a different cause for why it's going up, why can't I control the heart rate. Some of the other papers are talking about cardiologists were astounded how often we catch this on CAT scan. Kind of like the case that you just brought up. If we're looking for PE, they'll somebody's find the fluid, as opposed to if you found them seconds after you met them, you catch that much earlier.
Yeah.
Skip ultrasound.
What?
The answer is skip ultrasound.
No, that was the my personal lesson from that. I should ultrasound most of the people that come in with chest pain just in case.
But